everybody, at least in New York. It's morning, rainy morning. Hi, my name is Donna Shani. I'm a hematologist, meaning a blood doctor. I work very closely with the neurosurgical and the neurological department at Lenox Hill Hospital. And I very much want to thank the organizers for inviting me to talk about hematology and what turns out to be a brain seminars. And I hope to convince you that the blood is the most important organ when it comes to the brain. Brain without blood doesn't function very well. Thanks, Dr. Bukvar, for a great opening act. And now let me tell you what I do as a hematologist. So I'm ready for the first slide, Josh. Okay, so as you can see now, this is what a blood count, a complete blood count, or we call for short the CBC, looks like. We have here the white blood cell count listed first. There is a norm, which is between 4 and 11,000 in this case. This patient, whoever he or she may be, has a low white blood count. When we look at the blood count, we also look at the differential, what type of cells we have. And in here we have them listed: neutrophils, lymphocytes, monocytes, eosinophils, basophils. The ratio has importance, and normally the neutrophils are about 60 to 70% of the cells. The lymphocytes are about 20, 25%. And right off the bat, you guys can see here that we have a reversed ratio, and this is significant. The white count can be normal or low. When it's low, it's called leukopenia. When it's elevated, it's leukocytosis. And every time you have a low or a high white blood count, it's a cause for concern and explanation and probably a disease. Then we have the red blood cells, and they are also in a tight range between 4 to 5 million. As you can see, this is 10 to the power of 9, this is 10 to the power of 12. So we have many more red blood cells in the blood than white blood cells, and hence the blood is red because it's got red cells. The hemoglobin is the main protein inside the red blood cells, and that's what gives, this is the main function of the blood, is to give oxygen, lead oxygen to different organs, including the brain. And when the hemoglobin is low, you'll hear me talk about anemia. When the hemoglobin is high, we're talking about polycythemia. The hematocrit is another reflection of the hemoglobin. Then we have some other values here. MCV, which stands for mean corpuscular volume. We look at the red blood cells and the size of the red blood cell. And again, the norm is in a tight range between 80 to 100. When the MCV is too high, it's called macrocytosis. When the MCV is too low, microcytosis. And we like to talk about anemia, anemia being states where you have too little hemoglobin, either microcytic anemia or macrocytic anemia. By the end of the talk, you'll all be experts. And then we have some minor information here, MCH, MCHC. We don't pay much attention to it, and platelet count. Platelets are very important. As you can see there, we have a large amount of platelets in our body. I tend to tell residents that we have a redundant amount. We have between 150 and 400,000 platelets. And again, low platelet count would be thrombocytopenia, and high platelet count is thrombocytosis, and they're each associated with certain diseases. Next slide, please, Josh. So as you can see here, This is how blood looks under the microscope. Those are normal red blood cells. As you can see, there are many more red blood cells than white blood cells. Those are white blood cells. The red blood cells do not have a nucleus like those cells. They have what's called a central pallor. They're a little, because they are biconcave because of their shape. They look like a disc, and it's very important. The shape is very important, and when this shape is not preserved, we have diseases. This is the white blood cell. This is the polymorphonuclear, which I told you it should be about 70% of the white blood cells. This is another white blood cell that has a round nucleus. This is a lymphocyte, and again, they are about 20. In normal situation, we have about 25% lymphocytes in peripheral blood, and those are the platelets. And platelets come in various shapes. Some are big, some are small, and they are very important to coagulation. So roughly, I'm sure all of you know, as we said, the red blood cells carry oxygen, the white blood cell protect us against infection. And after, this is what I mostly do all day, look at CBCs and then look under the microscope at blood smears and try to make diagnosis. I'm ready now for the new slide. So let me now explain to you how this is all relevant for you as brain interns. How is the blood related to the brain? And there are a couple of scenarios. First is a known hematological disease, such as sickle cell anemia. Patients with sickle cell anemia are much more prone to ischemic stroke. Even young children with sickle cell anemia can get strokes. And next slide. Let's show you how sickle cell look like. Okay, so you've seen already a normal blood count, and this would be like a red cell that is normal with a central pallor. No white cells in this smear, but we have what's very prominent are those cells that look like sickle cell, like a sickle, like a banana. Use your imagination, whichever way you want to call them. Sickle cell anemia is prevalent in Africa. And in the United States, we have about 100,000 patients, mostly on the coast in New York or California. And as I said, stroke is prevalent in young patients and even in children. And therefore, this is a relevant disease to the brain. Next. So scenario number 2 is a neurological problem that is, when the neurological problem presents itself, so does that's when we are looking for hematological disease. For example, young patients with stroke who are getting diagnosed with protein C deficiency. And I promise you before the end of this lecture, you all know about protein C deficiency. Next, please. So scenario number 3 is multi-system disorder affecting both the hematological and the neurological system. For example, a young female presents to psychosis. She will go to a neurologist or to a psychiatrist, and they will obtain a blood count and realize that the patient has a low platelets. We'll start putting the things together. So this is not a mental illness. That can be a disease that presents with both neurological and blood diseases such as SLE or lupus. This is an autoimmune disorder affecting mostly young women and can cause problems in the brain and hematological one, like for example, low platelets. Next. And scenario number 4 is neurological symptoms that follow a hematological disease. For example, after treatment with chemotherapeutic agent, and now maybe it's the time to explain that hematology is divided between benign disease such as anemia, coagulation problems, and malignant diseases such as leukemia, lymphoma, myeloma. Again, a young patient with a stroke who has sickle, it might be called a benign disease, but it's certainly not so benign when a young patient or a child has a stroke. So I take care of benign and not so benign diseases and obviously malignant diseases. So when we treat, you know, and hematology exploded in the last 30 years of my life as a hematologist. We practically cure such diseases as childhood leukemia, Hodgkin disease, but all this comes at a price, and the price would be, we use strong drugs, chemotherapeutic agent, and one of them, for example, vincristine, commonly used, an old drug, tends to give peripheral neuropathy. So these people, you know, while I cure them, they might become a chronic patient for the neurologist because they always have problems with their sensation in hands and feet. The other drug like rituximab, which is not a chemotherapeutic agent, commonly used agent for the treatment of lymphoma, sometimes for treatment of lupus, thrombocytopenia, and so on and so forth. And it can cause a devastating condition called leukoencephalopathy, which is not even clear how the rituximab causes so much damage to the brain. So again, the blood and the brain are very much related. Okay, now let's go to some cases. Josh? Okay, so a case. Young patient develop pain and limping gait. Mom takes him to the orthopedic. The orthopedic does the x-ray, the CRP, the rheumatic fever. Nothing, he says, Mom, everything is fine. Maybe the neurologist can find a reason why your son has difficulty walking. It's a smart neurologist. He gets a blood count, and voila, next slide. So patient turns out to have acute leukemia. This is not a common manifestation, but acute leukemia is a very dramatic disease. After being a hematologist for 30 years, I still miss a bit, a heartbeat, I'm trying to say, when a new case of leukemia presents, especially in young adults. So what is acute leukemia? If you remember the first slide, it's acute leukemia, the main manifestation would be an elevation of the white blood cell count. Right? We remember the white blood cell count should be in a tight control between 4 to 10,000. And when you have an elevated 20, 30,000 white blood cells, the suspicion is for acute leukemia. And can we have the next slide? So how does acute leukemia look under the microscope? You've now seen multiple slides or 3 slides. Anyway, the red cells here are normal, very, very normal. But what you do have is those abnormally large white blood cells. Remember, I told you most of the cells, 70%, should look like this, polymorphonuclear with this cramped nucleus. This is not what's happening here. This is a large cell, much larger than the red cell. It's taken mostly by the nuclei, has nucleoli, smaller nuclei inside the nuclei. And this is how acute leukemia looks like. It's always a hematological emergency. And again, even if the presentation, this was a kid who thought from the beginning that he had, exercised too much or something like that. It turns out to be a hematological diseases. Next case. Okay, so a man with headaches, early papilledema, which by now I'm sure you know it's a little swelling in the optic nerve. The CAT scan turns out to be normal, maybe slightly abnormal MRI. Somebody smart does a blood count and the MCV is high. Just a reminder, the MCV is also tightly controlled. Usually cells need to be between 80 to 100 microns, and if they're larger, there is a problem. And what's the problem in this case? The patient has vitamin deficiency. Not very dramatic. This is not leukemia. It's a vitamin deficiency. Vitamin is an essential. Vitamin B12 is an essential vitamin for both the blood formation and for the brain. And people can suffer with anemia and some abnormal headaches or abnormal neurological find, very vague. And we gotta be tuned and do the CBC. And if I can have the next slide. So this patient turned out to have not just a vitamin B12 deficiency, but because of low vitamin B12, he had high homocysteine and cerebral venous sinus thrombosis. And we'll talk about cerebral venous sinus thrombosis if you haven't heard from it by the neurologist. And lack of a simple, what I'm trying to stress to you, that the simple vitamin deficiency can have disastrous effects on the brain. And how does vitamin B12 deficiency look in the blood? Josh, the next slide. One of my favorite slides in hematology. Again, this is a large cell, but the nucleus is polymorphonuclear, with actually too many polymorphonuclear. Normal white blood cells have between 3 to 4 lobes. This has one. Lobe is separated by a thin rim of DNA. So here we have 1, 2, 3, 4, 5, 6, 7 lobes. This is an example of severe. If you see this by looking at the blood cell, at this peripheral smear, this is how vitamin B12. This patient has vitamin B12 deficiency for sure. And as you can see, the red cells are also large. And again, a simple vitamin deficiency affects both the blood and the brain. Next. This patient presents, it's usually, again, it's a young patient, fluctuating neurological symptoms, maybe seizures, TIA. The MRI of the brain is really not significant. He comes into the hospital, we do a CBC, which is routinely done on any admission, and we find the platelets to be low. Something is going on here. Next slide, please. And what does this patient have? Another hematological emergency, a disease called TTP, thrombotic thrombocytopenic purpura. Again, it's an acquired disease. It's not leukemia. It's a benign disease, if you will. It does not require chemotherapy. Patients are usually young patients. It's seasonal, and they present with a pentade of symptoms: fever, headaches, vague neurological symptoms, low platelets, anemia, kidney dysfunction. And again, it takes an astute neurologist to see that, and to involve the hematologist, somebody like myself, and to establish the diagnosis. Okay, one more case, I think. Next slide, Josh. Okay, so case number 4, a girl with bilateral watershed infarcts. She's a young girl, so no hypertension, normal carotid Doppler, normal MRI angio and 2D echo. And next slide, extramedullary hematopoiesis. Because the slides, because the vertebrae are producing the blood and the bone marrow, and when patients are anemic, the bone marrow is trying to produce extra cells and expands into the spinal canal. Of course, this is a not commonly occurring manifestation, thankfully, but always devastating. Okay, so how does thalassemia look like? This is how thalassemia looks like. Those are, you can see some normal cells with a central pallor, but most of them are tiny, broken cells. And we have here a lymphocyte. The normal red cell should be the size of the nucleus of the lymphocytes, and everybody can appreciate that this is, those cells are smaller. There is alpha thalassemia, which is prevalent in the Africa and African American population. There is beta thalassemia, which is prevalent in the Mediterranean basin, countries such as Italy and Greece. And I know we have an international crowd here. In Italy, they call it the Italian anemia. It's even prevalent in Israel. That's where I am from. And what else can I show you about thalassemia? Hallmark of disease would be targeting cells. You see cells that look like they have a bullseye in. This is typical of thalassemia. Okay, so I think I've shown you enough blood smears, and let's go to other involvement of problems in hematology that can cause neurological problems. And I see I have the next slide up, and I'm sure you've been talked about strokes multiple times by multiple speakers. When I think about stroke, I think about the pump, the pipe, or the passage. The pump is the heart. I'm sure you heard from cardiologists about structural abnormalities in the heart, such as a PFO, patent foramen ovale. Anytime there is an abnormal passage in the heart that shouldn't be there, there is an opportunity for blood to travel from the venous to the arterial system. In the venous system, we can form clots more easily. The clot travels through the abnormal hole and can cause a stroke. But again, I don't want to steal the thunder of the cardiologist. The pipe, I'm sure Dr. Langer and Dr. Ortiz have already or will discuss with you structural abnormalities of the blood vessels, such as dissection, aneurysm, etc. That can cause stroke. And last but not least, and the diseases that I mostly talk about is the blood. And when when patients have what's called a hypercoagulable, when they're more prone to forming clots, they can, in spite of normal heart and normal arteries, form strokes. So most of my involvement with the neurosurgery and neurological department will be through patients, young patients or not so young patients who have strokes. Next slide, please. So what are hypercoagulability? First of all, when do we suspect hypercoagulable? Thankfully, I don't get invited to consult on every stroke patients because, you know, when patients have the usual risk factors such as diabetes, hypertension, obesity, then it's pretty obvious why they get a stroke. Why do I get consulted? When We have patients with cerebral venous sinus thrombosis, when the sinuses of the brain are getting a clot. That usually does not, it's not associated, it's not associated with diabetes, the usual risk factors. So that's when we suspect a hypercoagulable, meaning increased coagulability of the blood. Stroke in young patients, recurrent strokes in young patients, strong family history of, when patients come and say, oh yeah, my grandfather had a stroke in his 50s and my father had a heart attack at 45. So it's estimated that about 8% of the ischemic strokes, not the bloody, but the ischemic strokes, are secondary to a hypercoagulable state. Okay, next slide, please. So what are the hypercoagulable states? Here is a list: factor V Leiden, prothrombin gene mutation, protein S and protein C deficiency, antithrombin 3, MTHFR gene mutation. Factor V is a regular coagulation factor, but when it's abnormal, it's called factor V Leiden, and it's resistant. Usually when I think of coagulation, we have two systems. Let's start from the beginning of hematology. We have systems that make us make clots, and we have systems that make us break clots. So I often stand like this and show the patient. And when we have too much or too little of certain factors, then we can get either tilted to hypercoagulable or to a bleeding state. So as we said, factor V Leiden, when it's abnormal, it deems the normal occurring anticoagulants are protein S and C. And when you are deficient of protein S and C, because those are naturally occurring anticoagulants, when they are missing, you have increased coagulation because you do not have the anticoagulants. Factor V Leiden is a disease that factor V is resistant to anticoagulation by protein C. Because it's abnormal, protein C, even if protein C is normal, it doesn't get to act on it. So you get the idea that those are factors that are interdependent. MTHFR is last on the list here because I'm hoping no neurologists are listening to this talk, because then we often debate if it's a real risk factor or not. And I put here others just because I'm speaking to a young crowd, and some of you will end up going to a medical school, some of you will be medical researchers, and I'm sure when it's your time to present, the list will be much longer because you would have discovered many other hypercoagulable states. Next slide, please. So those were the genetic diseases that cause hypercoagulable. Of course, we have the acquired ones, antiphospholipid syndrome. This is a disease that I said to you we are associated with lupus. Polycythemia vera. Polycythemia, we'll say more about it. Polycythemia is basically a word that says too many cells. And when we have too many red cells, that is what polycythemia is. Essential thrombocythemia, this is when you have too many platelets. That makes the blood thick, and therefore there is more tendency for thrombosis and strokes. Other myeloproliferative disorders. We discussed sickle cell. We talked about the unpliability of those cells that look like a sickle and therefore causing strokes. By the way, we used to think of stroke only as a poor blood supply to the brain, but this whole stroke thing can happen in other organs, and like the spleen, and then It gives patients the typical painful crisis, especially when those little mini strokes happen in bones and etc. Paraproteinemia, when you have excess proteins in the blood, I'll say more about it. TTP, we talked about the Pente, the young patient that comes in with fever, neurological findings, low platelets. Homocystinemia, this is the patient, the last on the list was the MTHFR gene mutation, and they can elevation of the homocysteine. Homocysteine is a byproduct of vitamin B12. So the vitamin, when you are vitamin B12 deficient, which is a simple vitamin that should be available, you know, in the 21st century in New York City, we shouldn't see vitamin B12 deficiency, but I do see. Because vitamin B12 is deficient, the metabolism of vitamin B12 is abnormal, and this is homocysteine is a byproduct which accumulates and can lead to risk for strokes. And of course, pregnancy, birth control pills, diabetes, cancer, all those are acquired risk factors for strokes. Next. So when I get called to a young patient with a stroke, the basic workup, I said the CBC, the PT, PTT, prothrombin and activated partial thromboplastin time. Those are routinely blood coagulation tests routinely obtained all over the world today before surgery, patients with strokes, anytime patient comes into the hospital. The homocysteine level, the ANA, the VDRL, the lupus anticoagulants, just like I explained to you. This is the basic workup. This is usually done before they even call the hematologist. What do I do when I come to a case with stroke? Next. So I order all the list that I just told you, the factor V Leiden, the prothrombin, the MTHFR, protein S, NC, and the antithrombin 3. Next. Practical points, which I have to often remind my trainees, my residents, is depends on when do you do this workup. Because right after, I'm usually invited to the case, or right after patient had a stroke. So at that point, when patient formed already a clot, you can, if you measure the protein S and C, they can be reduced, but they're naturally reduced. They're reduced because the patient just had a stroke. So you have to be careful how you interpret. Also, sometimes I'm being called after the patient was already started on anticoagulation therapy. And the drugs we use, such as Coumadin or the DOACs, the direct anticoagulants, they are also affecting all those blood tests. So there are practical points to remember. I don't know. Yeah, I think I said enough about that. So, and now I think there isn't, I have a few more minutes. Yes, Josh?
Yep.
Yeah, okay. So let me tell you about some diseases that me as a hematologist get excited about. Iron deficiency anemia. I told you the blood is made of, although hemoglobin is made out of heme and globin, and when patients' hemoglobin is low, patients come with fatigue, headaches, they might end up, you know, in the cardiologist's office. Many times I find that they go to the cardiologist complaining of chest pain, they get a stress test and nobody checked their blood count. And the heart is already stressed by the anemia. So if you take a patient like this and you put them on a treadmill, that can be sometimes devastating because the heart, it's double stress test, I call it. But for some reason, neither the cardiologist, hopefully the neurologist, if they come with headaches, somebody got the CBC. So as I'm sure you can sense from my voice, I'm very incensed that a patient can walk around with undiagnosed iron deficiency anemia. Iron deficiency anemia is the most common anemia in the world. It's probably the most common hematological disease in the world. By the way, it can present with pegophagia. It's a very poorly understood phenomena, but if you have relatives that chew on ice, not on ice cream. If they chew on ice cream, they just like ice cream. But if patients of relatives chew on ice, they could have iron deficiency anemia. So the reason for iron, I said that in the United States we have what, 380 million people. About 12% of them are iron deficient. And of course, the percentage is much higher amongst young menstruating women of childbearing age or children. But, the one population that I tend to see a lot of these days is women or men too. After gastric bypass surgery, there is poor absorption of iron, and therefore they become iron deficient. Iron is mostly your fed diet, people who turn vegetarian. I know you'll read on Google that green leafy vegetables have iron. However, the iron in green leafy vegetables is not bioavailable to us, meaning we do not absorb it. So if you are iron deficient, you need to start eating meat or take iron pills. Again, 12% of 350 million people, you can see that no shortage of patients with iron deficiency. Next, sickle cell. What have I not said about sickle? Ischemic stroke, hemorrhagic stroke, seizures, sensory neuronal deafness. They can present to the neurologist. Moya disease. I'm sure Dr. Langer, if he didn't already, will talk to you about the prevalence of Moya disease and in patients with sickle. Next. Thalassemia. Patients with thalassemia, we saw the case with the extramedullary hematopoiesis causing the spinal cord compression. But this is the extreme case. People who come also with ischemic or hemorrhagic strokes, a little like thalassemia, but usually, slightly like sickle cell disease, but usually less. Next. Polycythemia vera. I'm sure all of you remember that polycythemia is just the opposite of anemia, meaning that patients have the red blood count is too high. If normal hemoglobin, we said, is between 12 to 14, these patients will come in with hemoglobin of 16, 18, hematocrit would be 49, 50. By the way, if the hematocrit is over 50, the first thing we do is we phlebotomize. We literally take blood off these patients. It's not blood that can be donated and used. It's usually tossed out, but this would be because if the blood is too thick, again, people are at risk for strokes, and the stroke would be from too much blood in this instance. Patients will present with headaches, dizziness, tinnitus, visual, blurry vision, cognitive changes, paresthesia, erythromelalgia, again, very poorly understood phenomena of, it's probably associated with autonomic dysfunction, and it gives you red, painful palms, which is not fun from what I hear from the patients. Next. Leukemia. Leukemia is, they can be either acute or chronic, and they can present with neurological findings, especially the ALL, acute lymphoblastic or lymphoblastic or acute lymphocytic leukemia. This is disease that is more prevalent in children. It's one of the diseases that we got to cure in my lifetime of 30 years of hematology. Really a lot of progress has been done in this disease. They often present with CNS involvement, leptomeningeal involvement. Those patients always get a spinal tap after we finish treating the acute leukemia to make sure. Also the leukemia is the CSF, the cerebrospinal fluid is a sanctuary for the leukemia cells. They hide there. So we often need to treat the CSF even when we don't find disease in there. And the way we do it, either by doing repeat spinal taps to put chemotherapy in there, or, the neurosurgeon. Actually, I met Dr. Langer. My first case with him was a case of acute leukemia in a 27-year-old. I don't take care of children, but he was a young adult. And Dr. Langer put an Ommaya reservoir, and I was able to give chemo to the patient through that Ommaya reservoir. This is the history of how I got here today. Next slide. So we talked about involvement in leukemia and lymphoma, that giving leptomeningeal involvement. Solid tumor, diseases such as breast cancer, lung cancer, melanoma are also diseases that can travel into the CSF. Patients present with neurological findings, headaches, nausea, vomiting, cognitive changes. The diagnosis is often, so they either present with masses in the brain or with leptomeningeal involvement. And the way to make the diagnosis is to sample the CSF, again, a spinal tap, and get the diagnosis. At Lenox Hill Hospital, since our neurosurgeons are so excellent, sometimes, the first presenting symptoms in patient with lung cancer would be a mass to the brain. And they go in there, resect the mass in the brain, and we make the diagnosis. Oh yeah, that's a secondary process, comes from a lung cancer, and we go and look for the primary disease. Next. So lymphoma, it's a disease that is not usually involving the blood. You can't find lymphoma in the blood. Hodgkin lymphoma is more common in young children. Non-Hodgkin lymphoma, it's more a disease of the middle age and the elderly. Sometimes there is CNS involvement of the primary lymphoma. And then there is another disease, to confuse issues, primary CNS lymphoma, which is associated with HIV or transplant patient, or we've seen cases, many cases at Lenox Hill Hospital. I'm not sure why it's more prevalent, but it's primary. Patients have no lymphoma anywhere else but in the CSF, and it's again, or rather in the brain. It's in the brain tissue, and it's a challenge to treat. Next. So plasma cell dyscrasia. I haven't spoken about plasma cells at all because they are not in the blood. They are only in the bone marrow. And what they cause plasma, they produce the proteins, the immunoglobulin. For example, when we check these days, the immunoglobulin or the antibodies to COVID, for example, who produces those antibodies? Well, I can tell you it's a plasma cell. Usually normal plasma cell in your body produce the COVID antibodies. However, if there are abnormal or malignant plasma cells, you get diseases. So when patients have an elevated, it's a disease of the elderly, and when the patient has elevated paraprotein in the blood and no other symptoms, it's called MGUS, monoclonal gammopathy of undetermined significance. And it can have sometimes peripheral neuropathy, so I get a lot of the referral from the neurologist. Multiple myeloma, when there is already much more significant production of those antibodies or immunoglobulin rather. They're not all antibodies. And Waldenstrom is another manifestation of another protein. Amyloidosis is a disease that we diagnose more and more. And again, they all can come with neurological symptoms such as hyperviscosity syndrome, etc. Next. So yeah, to sum up the paraprotein discussion is that every patient with undiagnosed polyneuropathy should have immunoelectrophoresis, meaning that the gamma globulins in the blood are checked. And urine Benz-Jones is a remnant of, but we practically don't do it in these days. How do we treat patients like this? This is often the next slide, Josh. Sometimes when the protein is so high, we literally put patients in a plasma exchange machine, which is like a washing machine, if you will, for the body. And we take people's plasma out, remove the extra protein, and return their plasma back to them. It's called a plasma exchange. It's also quite dramatic. Rituximab, splenectomy, and so forth. Next slide. Right. So I talked a lot about the hypercoagulable states. I said nothing about people with bleeding disorders, even so they are also common, but it's a specific population. There is a disease called hemophilia, which is the lack of factor VIII. Usually, this is the classic hemophilia. Patients can present with a bleed in their brain or subdural, epidural, any place in the brain can bleed in patients with hemophilia. Those are usually diagnosed in childhood, but there is acquired hemophilia, if you will, where patients develop antibody to factor VIII, and that's a disease of the elderly. And people come in with epidural or subdural bleed, and everybody's like, why? What happened? No trauma? What exactly happened? And it's very important to involve the hematologist to rule out acquired hemophilia. Next slide. Yes. So rare disorders, I just put it to tell you guys that I haven't discussed. If it feels like if I told you about the whole textbook of hematology, no, there is plenty of more diseases, paroxysmal nocturnal hemoglobinuria, graft versus host, transplant complication, porphyria, and whatnot. There is much more to explore. Next. And again, hematologic disorder of after treatment, unfortunately, the malignant part of hematology requires the use of very strong drugs, and such as cytosine arabinocyte, a common drug used in leukemia. And when you use it in the elderly, you can find, you cure the leukemia, but the patient has cerebellar syndrome, they walk on a broad base, they're very unstable, and so on and so forth. So although all my drugs are not benign, on the contrary, they can have toxicity and a lot of toxicity to the brain. So we have to be very mindful of that. So the take-home message of all the effect, I thought the acronym will humor you. The vitamins are the things that affect the brain: vascular, infective, traumatic, allergic, metabolic, inflammatory, nutritional, or neoplastic. and systemic diseases, as we said, like leukemia, systemic diseases such as lupus, for example. Systemic lupus erythematosus can affect the brain as well. So this is the end of my remarks. Thank you very much. Merci. Gracias. And I'm open to questions.
All right. Can you see on the bottom of your screen where it says chat?
Chat. I can see my, you know what? Now I don't need my slides, so let me maximize you. How do I maximize you? You know what? I have chat here.
You have it open on Zoom?
Chat. Yes, I see chat.
Okay, I'm going to open it up for you, and the question, then people will be able to ask some questions.
Okay.
I think one good question that people really like to hear is just like talk about your journey in your field and like how you got to where you are. And
so my journey, first of all, is old and ancient because I'm a graduated from medical school in 1981. And the main thing we did, you know, cardiology was involved a lot of listening. You know, we listened, we had the stethoscope, we didn't have echoes. Echo was a novelty. So we put, we had to listen to the stethoscope, to the heart sounds, and I couldn't hear anything. So I knew I won't be a good cardiologist, or at least I thought at the time with the available technology that cardiology was not the field for me. But I could see, as I showed you the slides, the hematological slides, looking under the microscope always excited me. So that's my journey by, you know, a little bit of the negative, the things I couldn't do, and a little bit of the things I could do.
can you see the questions that are coming in?
I actually don't. What am I? Oh, I see how I make chat. What exactly is Benz-Jones, BJP? That's an easy one. Benz-Jones protein. Forget about it. It was there for historical reason. What is your journey? Thank you. What do you recommend as a dietary modification for daily headache? Go see the doctor and find out if you are deficient in vitamins. I cannot practice medicine over the internet. I mean, yes, I can, but not not like this. I need to get more history. During cycling event, how many molecules of oxygen does hemoglobin typically bind? Got me there. Do not know. Good question. I can look and get back to you. For a patient with alpha thalassemia minor, as it is more than just a diet regulate instead of blood transfusion? No, so alpha thalassemia minor, I didn't go into the minutia of thalassemia, guys. But of course, there is minor and major, and you know, in alpha thalassemia, it can be deficient of 4 genes. In beta thalassemia, we only have 2 genes. So people's alpha thalassemia minor, it's assumed, like, for example, the MBA, you know, people who work physically very hard, it's assumed that 10% of the MBA has alpha thalassemia. So, and they are well-functioning adults, so doesn't require treatment. What is the cure for the low white blood count? Depends on what the white blood count is coming from. Sometimes a lot of the patients I see, the low white blood count comes from patient taking vitamins, bad vitamins produced somewhere, you know, in the far east. This is an international conference, so I don't want to label anybody, and you don't know what you're taking. Americans are big in taking vitamins, and about 20% of the cytopenias, meaning the low white count, low hemoglobin, low platelets that I see are coming from patients who take vitamins. But this is coming fast and furious. What's the more interesting thing you have throughout my career? Acute leukemia always excites me. Now, I'm happy with a boring day with iron deficiency. Why people with iron deficiency anemia chew on ice? I do not know. It's for you guys to find out and let us know. Tell us a bit more about beta-gamma thalassemia. And not sure about gamma. Beta thalassemia is the Mediterranean, people who are deficient of one chain, walk around with a little anemia, and not much else. Beta thal major, when you're deficient of both, it's a disease that requires lifelong transfusion, maybe bone marrow if caught early. Why do anemic want to chew on ice? Do hematologists also work with patients with kidney malfunction? No. The dialysis patients are anemic because of lack of erythropoietin, but the nephrologists are usually very adept at giving the erythropoietin injection with dialysis. Do you recommend multivitamin? Unless you keep the Mediterranean diet with everything in it, fresh fruits, vegetable, meat, then you can take one multivitamin a day by a reputable maker. Why do antibodies to COVID disappear? COVID is a new disease. I know about it as much as you probably, because they didn't teach me. I often say that, coronavirus, when I went to medical school, they talked about coronavirus for about 3 minutes because it was not, HIV came on the world scene, so we got a lot of respect. Hepatitis, other viruses got respect, not COVID. So the bottom line is that immunity to viruses is usually a cellular phenomena. So probably the antibodies disappear because another immune system. Antibodies is not the only immune system available. What is the future of hematology? Wow, how did the field change? My goodness, in my lifetime, we cure acute leukemia. I didn't touch on a disease, my favorite disease called chronic myelogenous leukemia, for which patient either died or required bone marrow transplant. And now they take a simple pill like Gleevec that now is not even branded anymore. And they live a long, productive life. So hematology changed amazingly in my lifetime. And I'm still very excited about it. Josh, you coming there means that I have to stop talking?
Yep, it's 12:01, but that went great. You were worried, but it went really well. No problem.
Oh, good. How many people dropped during my talk?
We have 700 people left still.
How many?
We have 700 left.
Oh my God! I killed 200 people.
But
no, it's all good.
Thank you so much for joining us today.
Okay. Thank you. Thanks for the opportunity. I hope some of you become hematologists. Forget the brain. The blood is the most important organ.
Have a great day.
Okay.